Wow, 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 wow. A warm welcome to you, colleagues. Welcome to the Clinical Care Platform. If you hear me playing our regular intro music, you know I'm back home. I was in the Bubalaga, the district of
Recording in progress.
Gatsebande, one of our NHI district rural area, and with doctors, pharmacists. But I really enjoyed engaging with community service doctors because at the end of the day, we need to love people and we need to add value to other people so that this journey can continue and they can empower other colleagues. So a warm welcome to you. I see you, Victor, Nginzi, Eva, Constance, John T. Micho, Zakaria, Jan Henrik, Khanya, Hazel, Jonathan, Jacob, Makito, Gomba, Nontlantla, Etoi. Colleagues, a warm welcome to you to the Clinical Care Platform, your home for professional development. All we want to do is to keep you updated. And it was so awesome to be in that area. I met so many of you working in rural settings with limited clinical supervision. And I was so happy. We even took a nice group picture. Actually, I should have added it on my slides just to share my excitement. And the week before, we had one in the East Rand here, Ekurhuleni with Dr. Mpo. I don't know if she's here. What an awesome experience to get a chance to teach, to empower. And I can't wait to join you on your ward rounds and do some clinical mentoring. Awesome, awesome stuff. So, yeah, today I am not alone as always. I'm with Dr. Lehlohonolo Magage. KwaZulu. Ke biditse pila, dokotela. Did I try? Magage.
Hey, good sir. Spot on as usual. Spot on as usual, sir. Good evening.
I really tried. I really tried, brother. Welcome. And I think in the Ekurhuleni one, you didn't know that I was there, and you were called to talk to HIV at the skid. But it was a nice surprise for both of us.
Thank you. Thank you. It was a pleasure seeing
Yeah.
you there, sir.
Awesome. So, colleagues, we do interface, and meet because that is what we have committed to do, to really spread the word and help every health worker to achieve their fullest potential. Yeah, so tonight we are going to be focusing on dermatology and we are looking at bacterial skin infections, and it aligns very closely with our mission to improve patient care. And I hope that you join us on this journey. If you are a member, I hope you are excited. You feel that you have made the right decision. If you are a non-member, you are like, yeah, I'm joining this train. I'm not being left behind. So we are so excited to have you on board. We continue to celebrate having issued over 100,000 credentials to various members. And, we can't just issue credentials. We rely on collaborations with clinicians like Dr. Magage. So we really, really appreciate that, Doc. Just to remind you as well, we are a membership-based platform. You have to become a member to get CPDs and reports and those kinds of things. But our education is free. It's open access. Please be empowered. Get as much as you can, but hopefully at some point you join us on this incredible journey. Colleagues, last weekend I had I don't know how many people. We were discussing how we can become more effective as health workers, how we can manage ourselves better, and we discussed how leadership is such a powerful tool to help us to create more time to empower other people to lead in our different spaces. I don't know what is it that you have put on hold. If there's anything that you would love to achieve and you haven't started, I'd like to encourage you tonight, make that decision and start. Why? You can't finish anything without starting. So taking that first step and starting tonight will be such a great achievement for you. Zig Ziglar says, if we don't start, it is certain that we will not arrive, Dr. Makake. So I know you have started so many things. Just to encourage you to keep going, my brother. I know entrepreneurship is not for the faint-hearted, but yeah, let's keep going. Let's keep going. Our leadership academy is coming, colleagues. We really want to help you, really, to achieve great things in life. And we think that if you are a great clinician and you are a great leader, can you imagine what's going to happen to our health system? We can't wait. This coming weekend, we have the masterclass in gastroenterology with Dr. Ryan Swepasat. Please do visit our website and join us on this journey. I will share the link as we continue with today's session. If you are our member, you have an additional 8 micro lessons from pleural effusion to high viral loads, pre-exposure using dapiring, diabetes and the eye. If you want to learn how to support learners with intellectual disability, just log in on the platform and start learning and becoming a better version of yourself. We are starting to develop the Academy for Quality Healthcare, and already we have a number of paid events from dispensing course to post exposure prophylaxis, pre exposure prophylaxis, cardiology, endocrinology, family planning, inserting an IUD, inserting a implanon, etc., etc. So please do visit our website, check it out. If you see Aqua there on the website, that's where the academy is coming. And Dr. Makare knows that's where the diploma is going to sit. Dr. Makare. Colleagues, let me not waste your time. We all know Dr. Makare. He is a specialist. Firstly, he's a medical doctor. Firstly, he's a husband. I know for sure. He's a great father because he always talks about his kid. I think one of them was it acne or something. I don't know. Or you suffered from acne. But anyway, he's a father. He's a husband. He's a medical practitioner. He's a specialist. He's a PhD candidate. He's an entrepreneur. And he is also the CEO of the Dermatology Institute of South Africa. What more can we get from him except the next presentation he's about to start? Dr. Makache, can I hand over to you? My brother, you see, I'm too excited. Ooh, okay, let's leave it at that. Thanks, brother.
Thank you so much, sir. Thank
What
you,
what
colleagues.
what are you wearing, Dogotel? Hmm? You're supposed to be to be doing. You're not saying I need you to zip. You're supposed to be doing this. It seems like you are somewhere here.
Yeah, man. Kaiser Chiefs all the way, bro.
Thank you, brother.
um, everybody can see my screen. Let me just share.
Yes, we
Please
can.
just confirm if you can see.
Yes, we can see it. It's full screen.
Great stuff. Thank you so much, colleagues. As always, such a pleasure being here today. Much appreciated to Dr. Mawela and the wonderful team there in the background. I've already been introduced. Today is a very important topic. When I was compiling this, I thought to myself, we should have had this talk a long time ago because by far, bacterial infections are most common. I think second only to viral infections of the skin, but really something that we see on a day-to-day, whether you be a GP, whether you be a specialist, a primary health clinic nurse, whether you're a clinical associate, these are common conditions that we see. So I thought today is befitting that we just look at the most common ones. Of course, there's a whole lot of plethora of them, but we're going to tackle the most common ones that we see in a South African and arguably in the African setting. Once again, Dr. Mawela and team, thank you so much. It's always so great being here. It feels like home to me. I'm really appreciative, and all of you who made time to come and listen in. I'm sure we'll have a wonderful discussion. I'll try not to be long. So you'll see in some of the topics, I'm going to be a bit more detailed. Some is going to be a nice overview. But I do hope that colleagues who made time to be here today will have something to take home, and that will aid in your patient care moving forward. So just the normal basic background. We've had this talk before in terms of the background of microbials. As we know, colleagues, the skin is the largest organ of the body. We like saying that it makes us feel good as dermatologists, but in practical terms, it means that it's more common side of trauma, common side for all the harsh elements coming from the sun and any other thing that you can, the exposure is that much more higher. So that is really the take-home message whenever we say the skin is the largest organ of the body. That already denotes to you that it's a target for so many pathogens out there. We do know that it's estimated that 1 million bacteria and hundreds of distinct species are inhabitants of our skin. So that's why, colleagues, it's not always advisable to do pass swaps on just all willy-nilly. I can swab myself now. I'm probably gonna get a MRSA, a E. coli that is resistant, and all sorts of viruses as well. So we never just want to swap. We know that bacteria is there, but it plays a very important role in terms of homeostasis and the interaction that we have with the outside elements. And we know that studies have shown that the microbes are good. So it's good for us to have those microbes. If nothing else, they populate so that we don't end up having pathogens, the more pathological ones. But as long as the integrity of the stratum corneum, the superficial layer of the skin is intact, then there shouldn't be any problems, theoretically speaking. It's not always the case, but theoretically speaking, more times than not, that tends to work out very well for us. And we do know, colleagues, from our talk we had in February, that it all depends. Different microbes react differently depending on the body side. Some like oily places, whether this will be bacteria, viruses, fungi, and even infestations. So you don't always get certain conditions they've got a predilection to a certain part of the body. So I think that is quite telling, and that's really what the slide here speaks on. And then they all live harmoniously together on our skin. And then we do know that many factors play a role in us getting infection. If maybe hygiene is a problem, our beauty routine, the climate plays a very important role. The issues of quality of health, stress, life style choices that we make, exposure to sun, and all of that. So that all interacts and plays a role in predisposing us to certain infections. We do know conditions like your uh, uh, conditions like eczema would go more for HIV positive individuals, as we're going to look into that. And then impetigo, for example, would prefer climate that is more warmer type of climates. That's where it thrives the most. And then all of that is actually part of homeostasis. We've thrashed this before, not only for the fungi, but bacteria and funguses and bacteria as well. And then as well, I think this is just an illustration, something I took from the Skin Atlas, that the local pH plays a role, humidity, comorbidities, age, immune factors. So all of that plays a huge role in terms of what type of pathogens are you prone to getting infected from. All these factors play a very, very important role, as we will see as we go on in our talks today. Colonizing bacteria, these are some of the bacteria that we have. There was a study that was done in the US, and then I just collated this from there. When I was compiling the Skin Atlas, we do know that Staph aureus by far the most common abundant bacteria that we get. A lot of times it doesn't cause us any problems. We see it around the nose, axilla, groin area. So it's really our friend. Everywhere we walk with Staph aureus. It's just that sometimes when the conditions are not favorable for us, and then infections will then creep in, different type of infections that we're going to be looking into. So, colleagues, without wasting further time, you'll know that a lot of my illustrations and talks will talk a lot about the skin itself. I always feel that it's important to speak around the different layers of the skin. We do know that we've got the epidermis. The epidermis is the most superficial layer. Of course, itself has got many layers. And then we've got the thicker dermis with all the adnexal structures there, the blood vessels, the nerves. So I always say, whenever you cut yourself, maybe you're in the kitchen preparing yourself a meal, accidentally you cut yourself, once you bleed, it means that you've actually cut through the dermis. That's the epidermis itself doesn't have any blood supply. So whenever you cut yourself, you bleed, you know that you've gone either into the dermis or quite deeper into the subcutis. So when we talk about conditions like your ecthyma, for example, those will denote ulceration. So it will go quite deep into the deeper structures of the skin. Whereas when you talk impetigo, it will be only the superficial aspect of the epidermis. That's why it would not scar. It will deal with scarring, because remember, scar is a function of collagen. Collagen is a structure that supports the natural structures in the epidermis. So it will make sense then in that sense. So we're going to be speaking a lot of conditions that would affect. We're going to speak very briefly towards the end around the subcutis. But more than anything else, we're going to be looking into conditions that are predominantly in the epidermis and the dermis as well. So this is the overview of our talk. I'll try to be brief, but I'm gonna be, as I said, detailed here and there. So we're going to talk about syphilis, impetigo. We're gonna touch on erysipelas, botryomycosis. It sounds like a fungi though. A lot of times I think pitted keratolysis, very weird and wonderful one there. And then we're gonna end off with erythema induratum and nodosum. I know even in my undergrad days, I would always get very confused between the two. So they themselves are marked in red because they are not necessarily bacterial infections, but they can be as a result of bacterial infection. And we just go into thrust those very briefly. So without wasting further time, the first one that we're going to be talking of, by far one of the most common infections, certainly we see in a day-to-day clinical. A lot of times we see this condition, but we're not really, we don't know that we are seeing this condition specifically, syphilis. So it's caused by Treponema pallidum. And then as we know, it's a STI. Of course, there are different other classifications, but for us, for practical terms, we know it as a STI, but there are different types that can be non-sexually transmitted. And then we do know that it's got this huge, it's got clinical stages. Primary syphilis, we tend not to see that in dermatology because a lot of that will end in the primary health care. So that will be colleagues who are working in a local clinic, local hospital. You will typically see that by the time it gets referred to dermatology, there typically wouldn't be much. So in dermatology, we tend to see secondary and hardly any tertiary. That's why I marked that in red. Just for interest's sake, colleague, this is how Treponema pallidum looks like. It's got this spiral waving spirochetes, as you can see there. This is the structure of the bacteria itself, just for interest's sake. It's not so important in terms of clinical, what we are going to be talking around now. So first stage of this primary syphilis, incubation period is 10 days to 10 weeks. Average time is 21 days. We do know that we call it the Hunterian ulcer. 2 weeks ago in our trivia, our weekly trivia, we had one patient with a painless so was it painful, painless? I forget now what I said, but that was one of the issues. That, remember, syphilis is hardly ever painful. So the only time that it gets painful if it's in itself is secondarily bacterially infected. But if it's a pure Hunterian ulcer, it will typically have the same chronology. Started as this papule, and then sometimes it can have a it can pustulate, and then it forms this shallow ulcers. One shallow ulcer, never ever multiple, hardly ever multiple. Let me put it that way. And then just remember that 5% of cases can be in the lip, oral mucosa especially. So please keep that in mind, that sometimes we don't always get it in the genital area, even though that is by far the most common area. And then always remember, colleagues, whenever you're dealing with oral ulcers, always have a systemic view on things. It's very important to think in that way as well, to have a systemic view. So herpes simplex, if I get somebody with oral ulcer, I'm going to think herpes simplex, I'm going to think Behçet's. SLE as in the strict SLIC criteria. SLE, we're still going to have a talk around connective tissue disease, but SLE, keep that in mind. Crohn's ulcerative colitis, of course, will have a bit more than that for us to make a diagnosis. So you still want to have a gastroenterologist to come in there. Hand, foot, mouth. But what I had in mind with this was to just keep in mind syphilis will also be here. Perhaps not as high on the list in terms of causes of oral ulcers, but certainly there as well. Just remember that syphilis can present, even though it's not as common for it to present in the oral mucosa rather than the genitalia. So it will heal by itself. Then 2 to 8 weeks later, then the fun starts. That's when we now see these patients in dermatology. So it will have different forms, how it presents itself. Anything from papules, crusting lesions. It can have all the syphilids, palmoplantar involvement. We know it's very common. So whenever you're not sure, especially if it's a very haphazard distribution of plaques, scaling, all of that, then you must look at the palms and soles, especially if it's asymptomatic. Colleagues, remember condylomata lata. A lot of you still don't quite know what that means, which is very important because that's part of secondary syphilis. And you must be able to differentiate condylomata lata from condylomata acuminata. I think I don't say this enough, even though I say it as many times as I possibly can. And then always remember, whenever you're dealing with secondary syphilis, always remember your nephritic syndrome, meningitis. Remember to look into the joints, examination of the joints and such. Very, very important, because sometimes we don't look beyond the skin itself. We're happy with making the diagnosis, but these things can complicate to a point of having syphilitic meningitis. So please remember that. And even then, this secondary stage typically resolves by itself spontaneously, which is the danger of this condition here, because it will later on form gumas, tertiary syphilis. We know that 10, 20 years down the line would have all these problems that will then come in as a result of that. And then hardly ever relapses. I think I've seen only 1 or 2 cases of a relapse, but we hardly ever get a relapse of secondary syphilis. This is one of the patients I had at the clinic. As you can see, the distribution is very haphazard. It doesn't really follow any clear morphology. And then I just asked the patient to flex a bit there to just show, to expose the palms. And then you can see there's quite a high palmar involvement with this patient here. Another patient I had at the clinic gave permission for me to take photos, as you can see there. Somebody who has, it wasn't really relapsing, but there were papules that were healing with hyperpigmentation. A lot of you colleagues would refer patients at a hyperpigmentation stage. So then you correlate the history. You look at the history, what is written on the referral letter, you find that it's written that the patient actually had these papules and a mixed infiltrate, whatnot, only to find now by the time the patient is seen, you just see PRH. Always do a RPR, colleagues, just in case. Do a RPR, because then sometimes it could have been a resolved syphilis that just never got the right treatment, but resolved by itself. So please keep that in mind. So some of the patients, the majority of these, I think 99% is photos that I took myself. So I can relate a lot to these patients here. Of course, they were gracious enough to give permission in written consent. but always look at the pumps and salts, as you can see here. The different severity, but the pumps and salts will almost always be affected when you are dealing with syphilis. And then, colleagues, as you can see, this is alopecia as a result of syphilis, alopecia syphilitica, as we call it. And then what I wanted you to take home here from this was that, yes, it can be quite subtle. As you can see, the photo on my left, quite subtly, you wouldn't necessarily see much. The patient head was complaining of alopecia, and then there's this moth-eaten appearance, whereas the one in the middle, you'd almost think of psoriasis, you'd think of seborrheic dermatitis perhaps, but in actual fact, when you take a complete look at the patient at the time, yes, it was like striking syphilis. So please keep that in mind, very important. Sometimes it can have this heme-like, almost urticaria-like morphology. A striking thing would be that it's asymptomatic, so it doesn't bother anyone. Doctor, I'm just not happy of how this thing looks. And then whenever you take history, especially the sexual history, you then learn that the patient actually had unprotected sexual encounter in recent time, because the time span tends to vary from patient to patient. So we have 6 to 8 weeks, but it's never really a clear time. So you must sometimes go back quite high on to get a clear history of what was happening there. I had this patient as well coming from the northern parts of the Free State, 14, 15-year-old boy, referred with tinea. I mean, you can see that it looks like tinea. It's annular, but then it's got this halo, this hypopigmented halo. Colleagues, please be able to differentiate between depigmentation and hypopigmentation. The two are not the same, and then they've got different clinical connotations. So this has multiple, certainly this is not in keeping with your typical tinea infection. So then I did a RPR on this. Of course, he denied unprotected sexual encounter, but it later came that it was actually, luckily the HIV test was negative. Always remember to do that as well. Of course, with the patient's permission, and if it's a minor or somebody underage, always know your provincial, the rules within the province that you are in, who can give consent at what age, because there's some subtle differences and nuances here and there. So that is very important in terms of you not stepping in the wrong footing there. I also had this lady. If you can see the morphology, it's almost the same as what we had with this hypopigmented. It's just that the borders are raised. These are more plaque-like. And then I asked her to also show me the pumps, and you can see the syphilis in there. So that speaks to secondary syphilis. And then I gave this lady doxycycline, and then for 14 days, doxycycline 100 milligrams BD for 14 days. And then it's also a good time to do a HIV test then. And then as you can see, the patient came back again 2 weeks later. One will have to appreciate the PIH, be able to differentiate, colleagues. On the one area here, this is PIH, post-inflammatory hyperpigmentation, not to be confused with melasma. This would be melasma. It's pigmentation, but it's not sitting at the same level within the dermis as well. So please keep that in mind, because that will have different connotations and different approach in terms of how you treat this patient as well. And then sometimes it can look like molluscum. That's why we say secondary syphilis is a great mimicker. Like sarcoidosis, for example. Sarcoidosis will also catch you out in that way. So all these patients that we've been seeing are actually secondary syphilis. And then as you can see, it can have quite different variations. This was quite peculiar. This patient actually had primary syphilis, but also developed secondary syphilis on the side here. This is actually signs of secondary syphilis if you look at the patient in totality. So sometimes it can happen that you have an overlap while the ulcer is healing. The secondary syphilis is starting on the same page, especially when the immune system is severely low. So please keep that in mind as well. Colleagues, remember to differentiate between condylomata lata. I will always stress this whenever I give a talk that is related. So condylomata lata is dome-shaped nodules that are ulcerated. A lot of times they are in the mucosal membrane, the same one that we have on our left here. This is condylomata lata on my left. That denotes secondary syphilis. And then on my right, it will be condylomata acuminata, that's HPV. As you can see, it's got that digitate morphology to it as well. So please be able to differentiate the two, because treatment is completely different. As you know that even the cause is different. Of course, this is Treponema pallidum bacteria, and the other one is a virus that would cause that pathology there. As you can see here, kiddies as well that would have come to our clinic. Mom would give us permission to take photos for only educational purposes, but appreciate condylomata lata, dome-shaped, well circumscribed, multiple ulcerated nodules in the introitus. That will tell me that this child is actually sexually molested. So that's why it's also important for you to remember it cannot be a touch infection. Condylomata lata is secondary syphilis and not a touch infection. So please keep that in mind. Whereas on this side here, it's got that digitateness. It could be sexually transmitted, could be that the child is molested, but many times than not, is more of a vertical transmission. Then you have to examine mom and make sure that mom is not having active genital warts. So that would have been the cause of this. So the connotations are different. Your clinical approach is going to be more or less the same, but then it will differ. Whereas you get secondary syphilis, which is condylomata lata, social workers must come in. You must involve the police. A police case must be opened because the sexual molestation that is going on here. In addition to doing HIV tests, the child must be taken to a place of safety. So please remember that, because condylomata lata eventually resolves by itself, and then you would have missed an opportunity to actually help this poor child take to a place of safety and such. So please keep that in mind. Another patient that I had with condylomata lata, secondary syphilis. Certainly look at the annular morphology of secondary syphilis. So that tells me that this child is being molested. So police have to come in, social worker, heads must roll whenever you see this. Why is that important? 2 weeks later, this would have completely all resolved, and you'd have missed an opportunity to at least take this child to a place of safety. So please remember secondary syphilis, remember condylomata lata. Whenever you are dealing with annular plaques like this, always remember to do a RPR and rather be suspicious rather than just giving a cream of salt. And then the patient resolves, you are happy, but you'd have lost an opportunity to help that child as well. This was a gentleman that came as well to our department, presented with this syphilis. He was of homosexual practices, and yes, he presented with this. They were asymptomatic, and then by just looking at them, I mean, it is a secondary syphilis. And then I also suggested you do a HIV test. If positive, you do a CD4. He agreed, and all of that came positive. The RPR with very high titers, and then also the HIV with CD4, and he was quite shocked, because he was in a very committed, exclusive relationship. So sometimes it can happen that you make a diagnosis of syphilis only to find that you are actually assisting the patient with the HIV matter as well, that you would have otherwise not been able to come to contact with. So on my left, ladies and gentlemen, I've got psoriasiform. So it looks like psoriasiform, secondary syphilis. And then on my right, I've got psoriasis. So you see how striking, and both photos I took myself at the clinic. So you can see how quite morphology can be quite striking here. Why would I not think psoriasis? I look at the nails. Once again, inside is very important. Psoriasis would have oil spots, will have pitting, will have onycholysis. It will have arthralgia, even though syphilis can present with that as well. And then it will also be the distribution, would say flexural areas, the elbow. You look at the scalp, for example, syphilis will also have the scalp, but the clinical variations can be quite, there's some overlaps here and there in terms of similarity, but a lot of times not so much. It's quite easy to differentiate between the two, but it can catch you out sometimes. And then always remember condylomata lata. It can actually occur in the tongue. I took this photo myself at the clinic. That's how I even did a biopsy. This was me actually preparing. This was a web call there because there was going to be a lot of bleeding there once I localized. So it can happen that you get condylomata lata, and then one would think Hex disease. The only thing that would give it away is that it's fairly localized, and then it would have gone away by itself a week, 2 weeks later. So once again, follow-up is very important with these patients here. So I was quite surprised when it came back as secondary condylomata lata, secondary syphilis, because I was actually expecting Hex that is quite localized in this patient. Another teenager that would come in, look at the morphology, completely different. You now think ecthyma, you now thinking MOD, deep fungal infection. Only to find this is actually crusted lesions that speak to secondary syphilis. And once again, why would they be crusted? Because crusting is the function of the dermis, because it's neutrophils, it's pus, it's all of that lymphocytic and also inflammatory cells. So that will tell me that that is in the dermis because there's blood vessels there. So as you can see here, so this was I think a week or so after treatment, the patient was already showing improvement there. And then another patient here, when you look at this patient, I honestly thought she's Caucasian, she's socioeconomically challenged, exposure to the sun a lot. So I thought this is actually squamous cell carcinoma. So to my surprise, it came back as secondary syphilis. So please keep that in mind as well. Very, very important. I wouldn't have believed it had it not happened to me, because I thought these are solar lentiges, sun exposure, secondary syphilis. I mean, rather squamous cell carcinoma, but it came back as secondary syphilis. There's a reaction called Jerix-Hexheimer reaction. It's an inflammatory response once you start the first treatment. It's not as common. I've been waiting for the longest time to encounter this reaction myself. I've never ever done so. This photo I took from one of the journals, but we hardly ever see this. But just for you out there, you might find this. If you see somebody with syphilis, you start treatment, and then suddenly they have this reaction, malaise, fever, body swelling. Just remember, sometimes if you're not sure what to do, consult dermatology. We give prednisone, very high doses of prednisone, and then sometimes we admit, we monitor in hospital, but then it tends to resolve by itself. So just please remember, whenever you start treatment, always give patient room for them to come back, whether it be side effect of the treatment you are giving or the reaction that would have been. It's almost like an iris type of thing. I wouldn't compare the two necessarily. The pathomechanism is not necessarily fully the same, but it's more or less the same type of analogy that one would have. So if I'm in a local clinic, I'm going to do a RPR if I suspect secondary syphilis, especially secondary syphilis, because primary syphilis RPR will sometimes be negative, especially in the early infection. If the syphilis is negative, RPR is negative, syphilis is unlikely. But if it's positive, then you're going to do a treponema test. TPHA is what we do in the South African setting, especially in the public sector. And then if it's positive, then you know that it could be a past or present infection. So it's very important to be able to interpret this. Somebody who's had syphilis before, they will always have a direct treponema test that is positive. So please keep that in mind. So that doesn't necessarily denote the need for treatment. for that patient. Treatment for secondary syphilis would be, for me, benzathine penicillin would be number one choice because it crosses the blood-brain barrier. It's highly, highly effective. 2.4 million units intramuscularly for 3 weeks means once weekly for 3 weeks. Other less quality options will be doxy, erythromycin, and also ceftriaxone. They are not as great, especially the oral ones, because they don't cross the blood-brain barrier. And as you said, the syphilis can actually go into the meninges as well and irritate the meninges there and cause meningitis. Doxycycline would not be your first choice drug in that setting, but if that's all you have, it's still quite effective. But if you have a choice, the penicillin, painful as it may be, it's quite effective in treating these patients. And so just remember, colleagues, in dermatology, because we work at a specialist center, it's always important to do a follow-up for these patients in terms of serology. So the RPR must be followed up. The titers must come down. You are expecting them to come down. If just finding an RPR that is positive with high titers doesn't necessarily mean, even if the patient clinically improves, you still want to know that there was a significant shift in the titers, that they were coming down. So please just remember that. And you can always look this up in the Skin Atlas, those of you who have access. It's quite a very practical way of just checking if your treatment is working well for these patients. And just for completeness sake, remember that sometimes you can get false positive RPRs. I always like to hammer students on this one because your second SLE can give you a false positive RPR, multiple blood transfusion, even advancing age. So anybody who's 50 and above, a lot of times RPR can be positive, but we know that the titers would be very low. They will be significantly low, and then they tend not to rise or anything. Then you know that you are sorted. But also, you can get acutely false positives. So that will be your pregnancy, which complicates things because if you're pregnant, titers are positive because that's part of our routine antenatal checks. So rather give treatment than not, But if you're not sure the titers are not coming down or anything, always refer to dermatology. We can always speak to microbiology as well because sometimes we don't always know what to do. Even Epstein-Barr infection, infectious mononucleosis can give you a false positive RPR. So keep that in mind as well. So colleagues, luckily for us, we don't see tertiary syphilis that much. But if we do, those of you who have seen it, I've never seen it myself. I don't wish to see it because it's got such destructive changes. But remember that you get granulomatous formations, gumas, central nervous system get affected there, papilloedema, they can have ataxia. Neurologists must always come in with this condition here. So it's not so much a function of dermatology as it is physicians that now needs to see this patient. Whenever you think syphilis are more in the secondary stage, primary stage is primary healthcare, but secondary syphilis would be more where dermatology will then come in, but tertiary is more neurology that would typically come in there. Second one that we have, colleagues, is impetigo, highly contagious, common infections seen mostly in childhood, Staph pyogenes, Staph aureus. We do know that it's got this honey-colored yellow crust. One of the patients I saw at the clinic. Yes, you can see this is quite extensive in impetigo there. And lucky for us, this is very superficial level of the skin. So that's why we like applying a cream. We like applying stuff because we know that even topical antibiotics are able to reach this quite nicely. But if it's quite extensive like this, it's not a bad idea to give your beta lactamase. Sorry, so that will be your clox, your augmentin would come in, anything penicillin would work very well. Erythromycin also quite a good choice there. And then we do know that we apply mupirocin, Bactroben, beta lactamase, and then if it's extensive, then local wound care with dressings is very important then for that. But I mean, very common in the childhood era. Colleagues must know what that looks like, and it's easy. It's easy to treat. There's no need to refer to dermatology. Impetigo is it's a primary health care quite a kind of condition. So when we talk impetigo, colleagues, once again, we are talking this level here, very superficial. But when we're talking ecthyma would be more or less the same pathogen. Staph aureus, of course, your other E. coli gram negatives would come in, but ecthyma would be quite extensive. It goes in there. That would then bleed and cause all this pus granulation and all of that because it's quite deep. It causes ulceration there. So that's what we are going to be talking about next. Ecthyma may begin the same way as impetigo. It just goes way deeper. And then a lot of times we see this in immune compromised patients. This lady here was in her 20s. She presented to me with this. And then already you know that you have to do a HIV test. So you sit in with her, you do counseling pre-test. Sister came in, did a test, and then it came back positive. So sometimes these infections are a doorway in telling you that the immune system is defective. And then those of you who attended the master class, you'd even think this is hemosiderin pigment. Remember, we spoke about dermatitis. So you'd actually think this is hemosiderin pigment here. In actual fact, it's not. But ecthyma, it was so deep that we could see the fascia and the muscle in there. So even after treating this patient would likely need surgery and then get grafting in that to close that wound there that had formed. And then sometimes it can be in other areas, not always in the legs. Sometimes it can be in the scalp. Look at this patient I also had some time back. Ecthyma, then I have to do a biopsy. I have to do cultures here because I'm thinking mycobacterium rather than TB. I'm thinking cutaneous TB itself. Scrophulodema can be one of those that can present in this. Of course, scrophulodema would be around the lymph nodes, but lupus vulgaris, at least the vulgaris of TB, lupus vulgaris, can actually present in this way as well. So please keep deep fungal infection, chromoblasto, not so much histo, but chromo at least can present in this way. So it's always important to do a HIV counseling for this patient so that you err on the side of cautions, and many a times than not, HIV test will be positive in these cases. Colleagues, I'm sure we've all seen cellulitis. It is common, also caused by Staph aureus, Staph pyogenes, and then it goes deep into the dermis. So that's why we need a systemic treatment. There's no value in applying anything topical for this. There's no topical medication that would have any impact for this condition. Very painful. The patient is not able to walk. One leg most likely affected. We've seen cellulitis before, and sometimes we can even confuse it with deep venous thrombosis to a point of actually needing to do D-dimers for these patients. Just remember, it's not only in the legs. You can get it in other places as well. As you can see there, the interpharyngeal space. You can see that. And then sometimes it can be confused with your septic arthritis, for example. So if not septic arthritis as a complication, it's also important to do reporting for these patients because you don't want that joint to be having pus under pressure because the patient can actually result in having amputation there. So very, very important to know and start antibiotics as early as possible. Do cultures so that you know you're on the correct path in terms of your antibiotic of choice for this patient here. This patient came from local here in the Free State. As you can see, the leg is quite beefy to a point of even forming this big bullae there. So always remember, whenever you're treating these patients, just make a spot diagnosis of cellulitis. Always remember bed rest, systemic antibiotics, very important, analgesics, very important. I always advocate for Clexane because DVT can actually become a complication for this patient here. And then always remember D-dimers as well to monitor. Sometimes I even send them for Doppler, just to make sure that there's no deep venous thrombosis that will then complicate into pulmonary embolism. And then you find that the patient was otherwise improving with cellulitis, but then complicated as a result of being immobile for quite some time. So please remember Clexane, remember Clexane, remember Clexane. I cannot stress that enough, because these patients, the mortality I feel like it's unnecessary for these patients. So please keep that in mind, colleagues. When we speak erysipelas, we speak in the superficial variant of cellulitis, if you will. So erysipelas involves the very superficial aspect of things, and then it will be typically the Staph aureus, Klebsiella, Streptococci that would cause this. So a lot of times these are very sensitive to common antibiotics that we have. So this is just a part in short for erysipelas, so that colleagues are familiar with it. Erythrasma, also very, one of my mentors, Prof. Ngozadlova, gave me this photo. Of course, you got it with permission as well. And then erythrasma, typically asymptomatic. Erythrasma is caused by Corynebacteria. So the differential here is quite long, because then you think Candida, you're thinking tinea of the groin area, you're thinking contact dermatitis perhaps. So there can be other conditions that would mimic this. So one has to keep a very open mind when it comes to erythrasma. But this is just for completeness sake. Whenever you're not sure if you're dealing with erythrasma, we typically, in a dark room, you switch off all the lights, make sure the room is completely dark. Then there's what we call a woods lamp. A lot of specialist centers will have a woods lamp. So you have a woods lamp, and then it's good to have this floral blue color that will then get accentuated when you switch it on. And then it's just quite a striking thing to see. It doesn't always reflect well in photos. I've seen a few on Google and such, but I've never been able to capture a nice photo to show you. But please, if you have time, have a look at Wood's light. It's not just for erythrasma, other conditions as well that one would benefit from Wood's light, from tinea capitis to a whole lot of things, porphyria, for example. So there's a lot of conditions. Botryomycosis, colleagues, uncommon, purulent, chronic, granulomatous, bacterial infection, and then it will have a whole host of causes: Staph aureus, Pseudomonas, Corynebacteria. And then botryomycosis, you would think it's mycosis, it's fungi, but actually the name is a misnomer. So sometimes you get this as well. It's in the family of your mycetomas. Perhaps there's a slight distinction between the two, but please remember botryomycosis. It will have this sinuses that would then form. Sometimes you'll have this inflammatory mass that will just sit in there, a lot of times asymptomatic. And then just quite a nightmare to treat this. Quite a nightmare. So please remember to refer to dermatology. It is a bacterial infection. We do biopsy. We make sure that we are dealing with the, botryomycosis. X-ray is very important, and sometimes we might talk to the surgeons to anticipate surgical debridement and such, to the best that we can, so that we preserve as much tissue, so that the patient can actually recover where possible. So please keep that in mind. Conditions that were common to us, colleagues: furuncles, carbuncles. So whenever you're talking about a furuncle, is a collection of pus involving the hair follicle. We call that a furuncle. Another name for it is a boil. Carbuncle is multiple furuncles. If it's grouped, we call it a carbuncle. So this will be an example of an early boil. We call it a furuncle. As you can see here, we've got a nice furuncle on my right, this patient here. Whereas here we just have a bacterial folliculitis. So they are follicular because they are coming out of the hair follicle, as one would see there. So please keep that in mind. And then this will be a great example of a carbuncle, multiple furuncles, deep boils aggregating together in one place. A lot of times the immune system is compromised here. This patient, for example, it was because of diabetes mellitus that would have caused this. Once again, you want to control the diabetes, but acutely, you need to give antibiotics that are sensitive depending on the microorganism involved there. Pitted keratolysis, colleagues, infection that is characterized by the small, minute pits, as you can see here. This is one of the reasons why a lot of people would have smelly feet. So please just remember, whenever you've got smelly feet, just always wonder, do you not have a low-grade pitted keratolysis? Because you could have a subtle bacterial infection and you're not even aware of it. So it's very important. I always think of the surface of the moon whenever I see a patient with pitted keratolysis, with those moon craters that look so beautiful. And then treatment here, dry feet, colics. And then, yes, it's sensitive to a whole lot of things, erythromycin, clindamycin, even peroxide. It is quite sensitive to peroxide, aluminium chloride, because it blocks the sweat pumps, so that keeps the feet dry. So please remember that sometimes pitted keratolysis. More than anything, the feet will always be sweaty, and then it's got this malodor. You are so sensitive to take off your shoes in front of other people because of this. So please just remember the treatment for this is actually quite simple. And then sometimes you are not even aware that you're actually having a chronic bacterial infection. So please keep that in mind, colleagues. In our WhatsApp group, we saw this, I think, 2 days back, bacillary angiomatosis. It looks so much like your Kaposi sarcoma. It's caused by Bartonella species, Bartonella hansale and Quintana. Yes, I remember in my reg days, we used to get hammered on those. And treatment for this, doxycycline, macrolides, but very, very important to always think of advanced HIV. And then because it's a vasoproliferative, that's why the morphology looks so much like Kaposi, because it goes for the blood vessels, hence the bluish, purplish tinge there of these nodules, because the pathology is at the same area where Kaposi would go, even though the species would be different. Kaposi would be human herpes virus 8 in the background of HIV in majority of cases, but this one would be a Bartonella species infection that would cause problems for this patient here. Colleagues, a few more conditions that we're going to discuss. I'm going to spend a bit more time on leprosy. We don't see it as much, but a lot of times when you see it, we are not able to recognize it. So I thought it's quite befitting that we speak around this condition here. So it's caused by Mycobacterium leprae. It's in the same family of Mycobacterium tuberculosis. Two main types. Of course, you get different types. There's a histoid type. There might be overlaps here and there, but lepromatous and tuberculoid would be very important. And a lot of times it's got this long latency time. That's why in the biblical years, whenever you are diagnosed with leprosy, you get what do you say in English? You get ostracized from the community at large, because we understood that the people you stay with, they can actually 6-10 years down the line, even without exposure to you, there's a latency period that is quite long. So please remember that. And it's got this insidious onset. A lot of times the numbness of the hands, feet, affected areas would be numb, and then the veins, the nerves would actually show. and then you can get sensitivity issues to light touch, temperature. A lot of times, more times than not, you get that. Very important. Please refer any patient with suspected leprosy. It is a notifiable condition. Please refer as early as you possibly can. Extremely important to do so. I cannot stress that enough. And then different types, perhaps not as important for you to know the different types, but I just know how both types presents. A lot of times they will present with madarosis, especially the lepromatous type would present madarosis is the loss of eyebrows. So a lot of these patients, and then leonine face, leonine is like a lion. It's like you've got a lion face, leonine face. So they will present with that. And then once again, colleagues, remember when we started, we said that all these bacteria and would go for different places. They've got different characteristics. So this one loves the colder parts of the body. Just like the cousin Mycobacterium TB will go for the um, right upper lobe of the lung because it's colder there. This one would also do that. Go for elbows, the knees, to go for scrotum, the ears. It really likes doing that a lot. This is what we mean when you say leonine face. It's got this lion-like morphology. Of course, there's a differential to the sarcoid, would have this granulomatous infiltrate and a few other conditions. Your mycosis fungoides, T-cell lymphoma can present in this way. Of course, then you have to look for specific areas, specific sites here and there to be able to make, and sometimes the benefit of doing a biopsy would be very important. But this is what we mean when you say leonine a clinical picture. This is a patient that once came to me. I wrote an article on this patient here. It was published and quite well received as well. Good sightings that I received there. I still continue to. So what happened with this gentleman is that he was staying alone, low socioeconomic. This condition is characterized with low socioeconomic, conditions. He stays alone. He already had this amputation of his little finger there, as you can see. And then he was complaining of this chronic nasal congestion. And then, as you can see, there's madarosis here. There are no, he doesn't have eyebrows. And then he had as well this thickened skin. As you can see, the skin was nice, thickened and coarse. And then he didn't have any feeling in the palms as well. It was a complete loss of sensation. He had peripheral neuropathy, couldn't feel anything there, like one would get with diabetes, for example. And then the one tip that actually scaled things towards me saying this must be leprosy was that ulcer there in the tip of the earlobe, because that's where leprosy would typically go. And then he also had gynecomastia. Why? Because of infiltration of the testicles. Then there's a reduced testosterone production, and then the little bit of estrogen that all male have tend to have a better advantage in terms of concentrations and such, and then resulted in that as well. So please remember that and treat as early as you possibly can. Refer, of course, you're not going to treat, but notify, refer. That will do a patient a lot of good, because this is what we sometimes had. I had this patient coming in completely. I mean, look at this. He could barely walk. I mean, his balance was off. He couldn't hold anything. I mean, even the leprosy left at this stage because he just couldn't go any further, because any further up for it, it gets too hot, too hot. The body temperature actually was too much for it, and it went away even without treatment. So please refer as early as possible these conditions, because we want to treat before it actually gets to be so debilitating. Now the patient has to be having a helper and be on lifetime grant and whatnot. A lot of times it would have been things that are preventable in that sense. So please refer, notify, and then the treatment for me in dermatology will give rifampicin, clofazimine, and dapsone. And then I'll also want to trace household contacts and close contacts and such, and even give them prophylaxis, and monitor them that they don't actually have Hansen's disease themselves. Mycobacterium other than TB. You can see how this can look very much like eczema. It can look very much like your chromo, deep fungal infection. So please keep that in mind. Tertiary syphilis can actually look like this as well. So whenever we're not sure, take a biopsy, even tissue. We tend not to go for pus swab cultures. We want tissue culture. Is that much more sensitive? We put that in saline and then you send it away, and then sometimes we take a H&E. So I'll take two biopsies here, one for normal histology, anatomical pathology, because then I need to see what the stains look like. Mycobacterium other than TB, it will be acid fast positive, your normal TB stain. And then if it's bacteria, it will be pus positive, PAS positive, and so on and so forth. So please remember, keep that in mind as well. So whenever you're not sure, rather refer. It's never a bad thing. The last few slides, colleagues, are going to be on erythema nodosum and erythema induratum. So nodosum, both of them will present with this painful nodules, especially in the shins. Erythema nodosum, mostly anterior. I'm not sure as to why it can be posterior in the calf area, but a lot of times it will be on the shins. Very painful, recurrent, and then this is what you typically get with erythema nodosum. Multiple, they look like just areas of macula, PIH, but in actual fact, when you palpate there, you feel that there's actually a degree of induration. There's a deep dermal component to them. So please remember that. And then the take-home message, if you forget everything else about erythema nodosum, please remember that it's got many causes, anything from oral contraceptives, drugs like penicillin, yes, as a side effect, it can cause that sarcoidosis. This could actually be cutaneous sarcoidosis. Remember your malignancy, lymphoma, leukemia, sometimes take a biopsy, especially if they are not remitting. By far oral contraceptives would be very high on the list, especially in ladies. That's what we always go for. And then you can get with superficial fungal infections, Epstein-Barr virus, infectious mononucleosis. There it comes in again, herpes simplex. But for today's talk, we're about bacteria. So you have to remember a streptococcus, especially in the throat, recent throat infection, or it can be this untreated recurrent or chronic infection of sorts from streptococci. TB itself can result in erythema nodosum, so please keep that in mind as well. And when we speak erythema nodosum, it's a paniculitis, so the pathology is in the fat. Remember when we started, I showed you the 3 layers of the skin. Erythema nodosum is in the fat area. So ideally, we want to be the ones doing the biopsy for these patients, because we literally cut an ellipse out of this fat. Maybe I should have shown you a few photos. I've got those where I've cut out the whole fat. So just to show that ideally don't do the biopsy yourself, rather refer to dermatology. It's better if the biopsy is representative, because then we are able to the patient is able to get a better quality of care in terms of what you are dealing with in such scenarios. Erythema induratum, it's an id reaction, meaning that we believe there's a TB somewhere. There was an article that came out that said it could be most likely endometrial TB. So we know that it's extra pulmonary TB. A lot of times extra pulmonary than it is pulmonary. So in itself, it's a paniculitis, but it's a bit difficult in that it causes a vasculitis. Maybe not vasculitis that you are able to see, but certainly when you take biopsy there, we see extravasation of red blood cells. We see lymphocytic infiltrate, especially it's got this dirty appearance, multiple neutrophils that we see there in the stroma, in the dermal stroma. That is in keeping with erythema induratum. So a lot of times we then postulate that there's a TB somewhere. It's very important that we monitor this patient and commit to either starting TB treatment And then there's two types of erythema ingeratum, the Basins type, which is more what we see in the African setting, but there's also the Whitfield type, which is more European setting. So it can be multifactorial. It's an ongoing thing. More research needs to be done when it comes to erythema ingeratum. But please remember, whenever these nodules ulcerate, these deeply seated nodules, once they ulcerate, you think more ingeratum than you think nodosum. And remember, whenever you're thinking erythema ingeratum, think more towards TB. Whereas when you speak erythema nodosum, then you're thinking along the lines of TB itself, but there's a whole plethora of things, as we said: leukemia, lymphoma, contraception, penicillin, Crohn's, ulcerative colitis. So this will not be about all of that. So the treatment here, a lot of times we postulate starting TB treatment, but ideally refer to dermatology. Let's be the ones rather treating this patient here. Colleagues, a few more slides. Remember, sometimes you can have a basic tinea that will then have secondary bacterial infection. So just for completeness sake, bacterial infection can be secondary. We do remember with eczema as well, we do get impetigination. So that can be something that happens. Very striking patients that I've had. Both of them were at the consultation at Universitas. So when you look at them, you just think erythematous plaques. But if you look very carefully here, colleagues, this gentleman here, it's a sharply demarcated area. You know that it's itchy. Why do you know that? Because there's areas of excoriation, there's a hyperpigmentation. That tells me it's been there for quite some time and it's itchy. And then it's got this pattern, you see where it starts, where it ends. It's well circumscribed. Whereas when you look at on my left, very haphazard, you don't really know where it starts, it ends. It's got palmar involvement as well. So this will be, and especially on history, the patient will be like, there are no symptoms here, doctor. It's asymptomatic. Whereas this one would be itchy. Even without asking the patient, you can see the skin tells you all what you need to know. So this will be secondary syphilis. And then this one here would actually be your tinea corporis, cruris, and such. So the two are not the same. The treatment is not the same. So please keep that in mind as well. And then sometimes, if you're not sure, we scrape hyphae and spores. Sometimes it can also bomb us out. So if we are not sure what we are dealing with, sometimes we scrape. But a lot of times, if we are well experienced, it's quite easy to be able to differentiate between the two. Remember, erythrasma can look very much like tinea cruris. So sometimes scraping also comes in very handy there, but also candida can be this way as well. So sometimes these things, contact dermatitis can look this way. So sometimes these things can be a bit of an overlap. So please keep that in mind as well. This could easily be erythrasma, it could easily be candida, could easily be seborrheic dermatitis, inframammary seborrheic dermatitis, could be contact dermatitis as well. And a few other conditions. Candida can present exactly the same if I didn't mention it. So you need to have a systemic view. These things can look very similar. But then if I think candida, I want to look at what's happening in the genital area, intergluteal. That's where candida would typically go. I want to look at the nails. I want to look at the web spaces. If I'm thinking erythrasma, I want to look at maybe I'm gonna have a patient wood slide. I'm gonna switch everything off and then glow the wood slide and see what happens. Inverse psoriasis can look this way as well. So please keep everything in mind. Have an open mind whenever you are dealing with these conditions. Colleagues, because of time, we were not able to tackle STIs. Remember your chancroid. Remember your gonorrhea. Those are actually bacteria. They affect the skin, but time will not allow us to look into that. Perhaps in future talks we'll talk more specifically around that. I think that will make for a very interesting discussion. These are patients that I saw at the clinic as well. We featured in the skin atlas as well. When we talk treatment, of course, you have to know what you are dealing with and its level of sensitivity, but it can be anything from beta lactamase, antibiotics, very high on the list still, very high in terms of sensitivity. Tetracyclines, quinolones can come in there. Macrolides are there. So please remember that, and always, always, always follow up your patients. Very, very important to do so. And then different mechanisms of action for different type of antibiotic. This we've done in the undergrad. We know that very well. Remember your layers of the skin. The epidermis is the superficial layer. So why is that important? Because you can actually apply stuff, creams and such. But then once it involves the dermis, the thicker dermis, once it's indurated, once it's ulcerated and all of that, you then think systemic treatment. I cannot stress that enough. And that holds true not only for infections today, but for a lot of conditions in dermatology. So in summary, cutaneous bacterial infections are common, limited value for a pass swab because of the natural colony of bacteria. Please have a sound approach, know your differentials, always follow up your patients, and then always refer wherever necessary. Thank you so much, colleagues. And thank you to all of those that have been supporting our brand. We are growing, as you can see. Next, we are heading to Gauteng. We'll have a big factory in Gauteng, hopefully this time next year. Thank you so much. Much appreciated. Back to you, Dr. Mawela.
Thank you so much. We are ready here in Gauteng. Ne? We are ready. We are ready. We are ready. Our
Thank you, sir.
skins, our skins are ready. So
Good to know, sir. Good to know.
awesome. Let me get you so that colleagues can see you as we go through a couple of questions. Colleagues, that's us right there. What do I want to do? Oh yeah, maybe let's start with my question as I open the others. What's your experience there in the Free State? Is there a resurgence of syphilis? I know that we are seeing a little bit more of congenital syphilis. From a dermatology perspective, are you seeing an increased number of referrals or cases? What's your experience, Doc? Thanks.
Yes, sir. I would say around the areas of Sasol,
Mm,
Sasol back. We are getting a lot of, if not referrals, there are a lot of consults coming from that area. So what we are seeing is sporadically here and there,
mm,
we get this mushrooming of cases.
mm,
So that also warrants us to always remember, Dr. Mawela, whenever you treat encephalitis, maybe I didn't even specify this enough, but
mm,
always remember it's an STI, so you'd want to also treat the other sexual partner or partners that the patient might have.
mm.
So please keep that in mind, sir.
Awesome, awesome. I see a couple of colleagues asking about the WhatsApp group. Hey, it's a buzzing one, that one, colleagues. You must wear your sunglasses. There's a whole lot of things being shared there, but all for learning purposes. It's very empowering. And Dr. Makake also shares on a Monday basis, on a weekly basis. I wanted to say on a Monday, a case of the week, and there's a lot of discussions around it. So we really, really appreciate this collaboration to bring this information to you. Dr. Malahle was saying, why does folliculitis decalvans always come back even after months of treatment?
Yes, we don't even know what causes it in the first place.
Mm,
So I think that's where we should actually start. We don't even know what would cause folliculitis decalvans. I
mm,
could have it next year. It's as
mm,
to why it chose me and not you.
mm,
We don't know. So because we don't even know why it happens in the first place, it's
mm,
very difficult to answer because I don't know if
mm.
that makes sense.
Yes, yes. Remind the colleagues what it is, Doc, because we have a variety here.
Okay, so folliculitis decalvans is a condition that it involves the hair follicle.
Mm,
It actually results in very tender, boggy scalp. A lot of times you sit on the scalp, and then
mm,
it has this boggy tenderness And then sometimes it will have discharges, and
mm,
it can be itchy as well, quite
mm,
diffuse involvement, especially in women.
mm,
But as to why that is, we don't quite know, Dr. Mawela. So sometimes we lucky we start treatment
mm,
anti-inflammatories,
mm,
and then it goes away. But then you find that sometimes it relapses again for the same reason that we didn't even know why it
mm.
was there in the first place.
Yeah, this one I heard you covering it very nicely, but maybe for Tererai rice, you might want to just clarify syphilis rings, annular rings versus tinea. What are the key features there?
Key features is that yes, with syphilis, it tends to be very random. It tends to not be localized to one place. It will
Mm,
be all over the show. It will
mm,
be asymptomatic. I think that will be
mm,
the main thing.
mm,
And then it will be, I don't want to say somebody who's sexually active, because you can get that even as a sign as molestation, for example. But more than anything, I would say whenever it's asymptomatic, one has to keep in mind that this could be secondary syphilis. A lot of times, more
mm,
times than not, secondary syphilis is asymptomatic,
mm.
whereas tinea would itch.
Just on a lighter note, is syphilis as artistic as the fungi? Because you know, fungi can draw very beautiful, expensive art. Does it do the
I would
same?
give yes, I would give syphilis higher, but then it will depend on the type of syphilis. The annular one, yes, sometimes can
Yeah,
be crusting and ugly,
yeah,
but then in terms of the artistic of the annular ones,
yeah.
definitely I would give syphilis there.
Awesome. This one is also on a lighter note. Don't Kulileko, when the webinar starts, says, hey, you guys, you are disturbing my margaritas. Now I have to attend the webinar. Sorry, Donku. Sorry. We know after a long day, sometimes people want to distract.
Yeah.
Kay says, after the talk about secondary syphilis, what I understood, so if you are lost in adult dermatology, do first a syphilis test. So if you don't know what you're dealing with, maybe just check syphilis. Would this approach work?
I think so. I think for the same reason, Dr.
Yeah,
Mawela, that all pregnant women
yeah,
we do RPR as a standard,
yes,
RH, HIV, RPR.
yes,
So I would say I would agree as much, because sometimes you could have had it and
yeah.
then you find that you are now asymptomatic, but you are asymptomatic carrier that is
Mm.
actually spreading it even more.
Awesome. You didn't talk about the Atlas today. I don't think I've heard you referring to the Atlas. Would you like to tell? Because I had a link to share with colleagues. Usually, I wait for you to say this one from the Atlas, African Skin Atlas on the material. Then I post it.
Yes.
Would you like to say
Yes,
something
yes.
about it?
Except to say that colleagues have been exceptional in supporting the Skin Atlas. It's available on Take a Lot. I still have a few copies myself if you'd like to.
Hmm.
You can join the WhatsApp group. My number is there as well. But
Yeah.
then it's also on Take a Lot. I think, Dr. Mola, as I always say, dermatology is not well covered in the undergrad, and we see
Hmm.
these conditions on a day to day. So the
Hmm.
Atlas was really meant to, as much as possible, bridge the gap between
Hmm.
what was not learned in the undergrad and
Hmm.
what we see out there in the setting. So those of you who see
Hmm.
such patients who would want to know more and be
Hmm.
better clinicians, I
Hmm.
think Atlas would be a very good tool to use.
Yeah, I see someone says we must put it on the platform. Are you done with your initial? I don't know. When you produce the book, usually your first few copies you can't sell them anywhere. Can I order some, put them on the platform for colleagues to buy, and we become a take a book?
Yeah, why not? Take a book. No, nothing wrong with that, sir.
Because I saw someone says put it on the platform. I'm like, hey, okay. And I think at
Yeah,
some point we discussed this. I think I must. we will. We will talk via WhatsApp. So David
yes.
says, how does eczema differ from venous ulcers? Yeah.
Okay, yes, very important question there. We thrashed that in the previous master class, but venous ulcer, it means that the venous system is not able to drain well. The deep venous system, the valve is dysfunctional there. As a result, the blood that is supposed to be draining back into the heart via the venous system is sluggish in the legs. So then what happens is the surrounding skin is unhealthy, and then that then results in the ulceration because of those accumulation of metabolites in that area there. Whereas when you speak ecthyma, it can be anywhere in the body. It's a function of infection and in the background a lot of times of HIV. So then you can get that anywhere. Whereas venous ulcers are almost always strictly on the legs. So they can look the same, but yes, there's a lot of variation in terms of, and the treatment as well, it will be completely different.
Awesome. Awesome. Anonymous says, can augmentin work against syphilis? Hey, syphilis is
Not that I know of.
problematic.
No,
It
no,
requires
no,
a.
it's not listed.
Mm,
It's not listed. Benzathine, penicillin,
yeah.
Pen-G, doxycycline, ceftriaxone, azithromycin. Those are
Azithro.
the ones that are, yes, but not penicillin. No.
Is it Alexandra Fleming, the Nobel Prize winner? Penicillin. I think so.
Yes,
Yeah.
yes.
Sibuti
Yes,
says
sir.
hidradenitis suppurativa. What are the key principles there in terms of management?
Management of HS, it depends on the Heli stages, clinical stage, Heli stage 1, 2, or 3. So that just means how severe it is. And then remember, those of us who don't know what hidradenitis suppurativa is, we've got two types of sweat glands, eccrine and apocrine. Eccrine sweat glands, you get those are thermoregulatory. So I'll get them in my forehead. Think whenever you are exercising, where would you sweat the most? To be the axilla, palm soles, the forehead, the scalp. So apocrine is a function of sexual characteristics, people who come into adulthood in terms of manhood or whatever. So you get that in the axilla and the groin area. So whenever the duct get blocked, that we call hidradenitis suppurativa. So then it depends on the severity of the blockage. Then we characterize that by Heli stages. So stage 1, 2, or 3. So anything from anti-inflammatory, dapsone can be used, systemic retinoids can be used, and sometimes we might even consider surgical excision, especially if they're in the axilla and never in the groin area.
Doc, what are the standards regarding internship or ComServe and dermatology? How much time are we supposed to spend there? I think there's a problem there. You
Yeah,
see, that's
no,
where, because hey, this
that's true, sir.
dermatology,
Yes.
yeah.
And I think derma is actually quite easy. I think I was also a GP myself. I couldn't treat eczema. I wasn't confident at all in dermatology. So that's one of the reasons that said, let's have such talks. And then you having this platform is helping a lot of people out there who did not know how to just connect the dots. So, but once you qualify, all that knowledge, once you qualify, that's all you will ever have, unless you attend such platforms as yours, because there's no rotation for dermatology in the
Dermatology.
internship. Certainly, ComServe, you're on your own.
Your
So
own
we say you are
in the
serving the
rural
community.
corners. Yeah.
Yeah, so that's where the problem is.
Hey, yeah, no, we must advocate for our discipline. Yola says, do you need to puncture that bullous? Remember the patient who had a, yeah.
Yes. No, you don't need to puncture it for three reasons. A lot of times it's a transudate in there. So transudate facilitates for better granulation of the underlying dermis. Remember, bulle denotes a split between the dermis and the epidermis.
Okay.
So in between there, where the fluid comes in, a lot of times that's a transudate. So transudate rich in protein, so that helps a lot with wound healing. Secondly, you don't want to puncture it because you then need to dress it every day. So it is quite costly to do that. and you still need to give analgesic because those nerves in the dermis are now freshly exposed. You now need to give antibiotics, analgesics, and then it might get secondarily infected, denoting you to give
More problems.
antibiotics, maybe not for cellulitis, but now for that wound that is now left open there. So ideally, if you don't need to, those are natural dressings that are there. Once the antibiotics do their work, that leg skin will just fall off on itself. A lot of times granulation would have taken place already. So that's actually a good thing for us.
Awesome. Olga says,
But
can
that's
we?
a good question.
Awesome.
That's an excellent question there that she's asking.
Yes. What's the role of Clexane in cellulitis? I think I should ask it this way.
Yes. The role of Clexane in cellulitis is zero,
Yeah.
but we do know that patients with cellulitis are immobile. There is bed rest is part of the rest, so we get angry at them if they walk around. So we don't want them walking around. But unfortunately, once you sit for a long time or you rest for a long time, the flow of the blood is not as good. So it can get prone to getting clots. So because of that, that can predispose you to DVTs, which in any case, we wouldn't be able to see clinically at that time because the leg is swollen because of the cellulitis. So that would mask an underlying DVT to a point of actually getting pulmonary embolism. So Clexane itself is not about the cellulitis, but the complications that can arise from the lack
Okay.
of mobility for that time.
Okay. And would you recommend it for children as well?
I wouldn't, but yes, I have never seen cellulitis, especially in the legs in children. It's just impetigo, yes, but cellulitis is not something that I would see. I would want to discuss with pediatrician then see if maybe it's not an underlying other causes there rather than cellulitis. That would be a problem. And in any case, children having DVTs, I've never heard of that. I stand corrected, but that's not really a thing. That's not a pediatric issue. It's more issue with the adults.
Okay. Okay. Awesome. Awesome. Leonine. It depends which school you went to. Can we go for another 5 minutes, Doc, and see if we can take two more questions? I see we
I'm
have
all
so many.
yours.
Okay, yeah. And then the FCOG colleagues, Dr. Magugula says we will start at quarter past, so maybe he's buying us time. So do you have a picture of Leonine? How do you pronounce this?
Leonine, it's
Oh,
lion-like.
nine. You
Looks like a
see,
lion, yes.
Leo
Um,
nine.
I have we see a lot of patients who are leonine. Even your chronic actinic dermatitis can give you that. So what I would say to colleagues is if you go on Google and you type leprosy face, a lot of times you'll see leonine, or just go and type leonine face. You will see a lot of conditions. It's a common thing. It's so common that it's not even specific to leprosy. You can get it, as I say, chronic actinic dermatitis, sarcoid, mycosis fungoides, which is a cutaneous T-cell lymphoma. So just getting leonine phase doesn't necessarily denote that you've got leprosy, but it's suggestive. But then you have to have a clinical examination. But colleagues, feel free to have a look on Google.
Mm,
You'll see a lot of content, even better than what I have on my discovery, the patients that I've taken photos of.
mm. I don't know if we discussed folliculus decalcans, but Kamohelo is talking about maybe in terms of treatment why doxy is delayed, etc. I don't know if it's the same response you gave before or you want to add.
Um, I wouldn't necessarily delay. I would just say, for folliculitis decalvans, it's not an infection. We don't give
Mm,
doxycycline
mm.
as an antibiotic. It's an anti-inflammatory. The
Okay.
same way I would give you doxycycline for acne, for
Acne.
rosacea.
Mm,
Yes, it's not so much the anti. So we give a lesser dose for longer duration as an anti-inflammatory. Is our off-label anti-inflammatory in dermatology. So there's not really a need to delay. I would want to look at a clinical picture first, and then I'll take it from there.
Awesome, 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 awesome. I was just checking. Someone said they would share a picture. I was just trying to see if it was sent. Barbecula says, I once had a patient with a history of being forced by boyfriend to take 2 bottles of ARVs at once. Later presented with painful, I think, rash extending to the lower abs. At a glance, we thought gangrene starting. Now she has lost all fingers, still refusing referral. It's been a year and she recently lost a finger. Could the overdose be the cause of leprosy? I don't know.
Mycobacterium
Yeah,
leprae.
yeah.
Yes. So
So
I
she
don't
does
think
have
it's
it, but I don't think it's due to the overdose, right? Not.
no, no.
No, no.
Yeah, I
Yeah,
want to take. I would like to history taking, and then
yeah,
maybe good clinical examination
yeah,
myself. Perhaps the paragraph doesn't give justice to the full clinical picture for
yeah,
us to confidently make
yeah.
conclusions there.
Yeah, so maybe Babegile, let me get that link again for the WhatsApp group. Join the WhatsApp group and then provide a very good comprehensive picture. Ideally, you also want to take very good quality pictures without disclosing the privacy of the patient. So we must keep it intact, and then we take it from there. Yeah. And then maybe Fundiswa says, is erythema multiforme different from the other 2 erythemas? You mean the ones that were mentioned in the presentation? It's too open to respond to it, but maybe are you able to figure it out, Doc?
Is erythema multiforme? I didn't get that.
Says, is it different from the other 2 erythemas?
Yes, yes.
Yeah,
There's
probably.
erythema
Yeah.
induratum and nodosum.
Mm,
Multiforme is that one that is annulized, got this targetoid lesion in there.
yeah.
It's caused by herpes virus. It's highly associated with herpes.
Mm,
It's different from even erythema marginatum. There's a
mm,
marginatum as well,
mm,
and that is rheumatic fever. So just the erythema just means it's red, it's inflamed.
mm,
As to the cause, it can be induratum, marginatum, nodosum.
mm.
So it can be many different causes of that.
Awesome. So someone is asking, is leprosy a notifiable condition? And in your experience, is it how common is it?
It's not as common,
Mm,
Dr. Mawela, but what I would say is that for me personally, I think the biggest problem is we see it late.
mm,
The cases that we see, and a lot of times they will have permanent complications that were otherwise unnecessary. So for me, it's not as common, certainly. We see it a lot in India. I see even my article was cited mostly in India, Nepal,
mm.
socioeconomic countries that are low. I even mentioned with this patient here,
Love it. Love
for my
it.
friend. Yeah,
Yeah.
yeah, yeah. So it's like that, sir.
No, no, no. Awesome. Awesome. Colleagues, I think we have really tried. I was trying to see if I can slot in one more question. I think it will be an over extension. Dr. Makahe, just wait a bit. I want to see. Nerissa had asked that she wants to, and I had said she must. So if we can just do this one, it would be all I'm asking of you, my brother. Apologies. I know
No problem, sir.
it's already. Actually, let me open on my, because she did post very early on. And I said she must share, and then I'm gonna give you Nerissa to narrate the history, and then we're gonna close. It's gonna be our season finale. Let me see. Maybe let me start with the one that has minimal privacy stuff. Nerissa, I would love to give you to talk live, and then it's gonna be our season finale. Nerissa, let me find you, Dr. Boshoff. Yay. Okay, would you like to unmute to talk about, and then I will share the picture for Doc to see some of them. Yeah.
Good evening. Thank you for letting me speak. So this was a 3-week-old baby that presented to my office today. Um, in the skin folds, it almost looks like a fungal infection because it's all in the skin folds. But when you look at it in person, it looks complicated with a bacteria, like a bacterial infection. But what's interesting is it pops up in all different areas. So once the one area improves, it will pop up in another area, but it's all in the skin folds. And then also the baby's bottom, the nappy area is also infected with the same thing. And then sometimes there is contact bleeding when they're trying to clean it.
I was trying to show you a little bit more pictures, Doc, but I think my Zoom is not allowing me to. But yeah, I don't know if okay. Let me see if I can try again.
Yeah.
To share
Okay.
one more. Screen
That
is.
picture that was shared,
How is
that
it
was
now? Can you see
shown,
it
it
now?
was
Yeah.
behind the ear.
Yes, I can
And
see.
then you can
I see the
see.
nappy area.
Yeah.
Yeah. Yeah. Okay. Sure. Yeah, yes, but this is not so detailed. Nerissa, I would like us to discuss this maybe tomorrow. I don't
Okay.
know if you're on the group. If possible, mommy gives permission. Maybe you can share on our WhatsApp group. Let's have a look and see. I'm a bit worried with this child. What is it that you are dealing with here? Because sometimes it can be some things as rare as your primary immune deficiency. And then you find
Yeah.
that this is actually an immune deficiency. I remember we've had a child with a IgE deficiency and such complement deficiency. So I would be very curious to see, but if nothing else, please share on the group. Let's have a look. Let's have a good discussion there. But it will be safer to refer to dermatology for a thorough clinical examination for this kid. It sounds like it's not your average skin rash that you typically see in the pediatric setting.
Yeah, no, definitely. Thank you very much, Doc, because it's a social kitty. It's a kitty that's in the system. So mommy is not even around anymore. The mommy was a 15-year-old kitty. So there is not even much history also.
Shame.
Okay, no problem, doctor. Thank you so much for
Thank you
sharing.
so much.
Much
Yeah. Are
appreciated.
you in the group,
Yeah.
Dr. Boshoff?
I've just joined the group. Thank you,
Oh,
Dr.
okay.
Mboila.
Okay. Awesome.
All
Awesome.
right.
Awesome. So at
Okay.
least then you have the link. Okay. Yeah.
Thank
Thanks.
you.
Thanks for
Thank
volunteering.
you.
Yeah. All right, colleagues, that's it for the night. This is what we are all about. We just want you to feel good, to be very confident, to be ready, if we can, for the patient you are going to see tomorrow. So yeah, thank you for joining us this evening, Dr. Makhache. Your parting words to colleagues, and then we call it a night.
Yes. Once again, colleagues, thank you for making time. I'm always so looking forward to coming into the platform whenever I'm here. I really enjoy doing this session. I think we covered a lot of common conditions, and I do hope that it will have impact for your lives out there when you see your patients. And to the clinical care platform, thank you for having this. Thank you for the wonderful work that you do. Much appreciated until we see each other again. Thank you so much.
This is it. This is it. I sometimes forget that I have the trumpet. Let me find it. Where is it? The horn. Is it this one?
Very
At night. Colleagues, that's
good.
it for tonight. If you are not a member of the platform, I think you need to reconsider why you are not. What would you lose really for joining this platform? I think you have a lot to gain from this platform. On that note, let's call it a night. Thank you, brother. We will talk on the sidelines. Thank you.